All right. Welcome and thank you for joining. My name is Ashley Lusick, and I am a health educator for community health at Atlantic Health System. Today's webinar is Prostate Health Awareness Series, Sexual Health and Fitness with a Diagnosis of Prostate Cancer. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or the chat for comments. We will try and get through all questions at the end of the presentation. At Atlantic Health System, we encourage everyone to be an active partner in their healthcare. We recommend using an online tool called MyChart to help you manage your care. MyChart is an interactive tool that gives you 24/7 access to your electronic medical record. Anyone who is a patient with Atlantic Health System can open a MyChart account. This includes anyone who has visited an Atlantic Health System provider for routine visits, vaccine visits, or even an Atlantic Health System emergency room visit. If you are not a patient of Atlantic Health System, you may have access to MyChart or similar platforms through your usual provider. MyChart allows you to manage many aspects of your healthcare. Some of the most popular features allow you to request your medical records, access your medical information, test results, medications, allergies, diagnosis, send non-urgent messages to your provider's office to request medication refills or ask questions, view your clinical notes and after visit summaries, schedule appointments online, e-check in for appointments, which makes the check-in and rooming go much faster, share your MyChart with family, friends, and vice versa, and many more features. If you want to set up a MyChart account, need help logging into a current account, or have questions about how to use MyChart, there is help available 12 hours a day, 7 days a week. We recognize the fear, uncertainty, and confusion that surrounds making decisions related to musculoskeletal pain. In a sea of information overload, it's hard to know what's what and where to go for orthopedic care that you need. Atlantic Health System has your back the entire way. When you've got questions, we've got answers. With that, I am first going to turn things over to Dr. Joseph Caputo.
Thank you, Ashley. Appreciate the introduction and that information. So thanks everybody for joining for the third part in this series on prostate cancer. I think we have a good talk scheduled for all the participants today. Today's talk is going to be geared more towards the recovery and what we can do to try to help improve sexual function, and then Diana is going to also talk about urinary function after prostate cancer, treatments. So I work, through Atlantic Medical Group and part of the urology department here, and my specialty is in men's health and male infertility. So that's part of the reason why I'm giving this directed talk. I have no disclosures for my presentation today. Just some outline of goals for my portion of the talk. So we'll define erectile dysfunction, review some statistics and the relevant anatomy for erections, and then discuss why prostate cancer treatment specifically impact erectile function. We'll discuss the treatment options that are available, and then at the end I'm just going to give a quick kind of rundown of what's called penile rehabilitation, which is kind of some controversy to it in terms of what's the ideal programs that are out there for men, after prostate surgery to regain or recover their sexual function. So probably included in previous talks, just some, background in terms of prostate cancer. So this is the estimates from the American Cancer Society for 2024. So there's an expectation that 300,000 men in the United States are going to be diagnosed with prostate cancer this year alone. And it is the most common non-skin cancer in the United States in men. And then if you look at the lower diagram there, it talks about the estimated deaths in 2024. And there's an estimated around 35,000 patients with prostate cancer that will die from the disease alone. So significant impact in terms of prostate cancer, on society and on health. And, as probably discussed in previous talks, we have really good advances for treatment of prostate cancer to minimize, morbidity and mortality related to treatments. But there are, risks associated with these treatments, which we want to discuss and how we can improve them. So just to reiterate, prostate cancer is the most common non-skin cancer in men, typically average effect of 1 in 8 men. Despite those high numbers, many men, consider themselves prostate cancer survivors. Over 3 men that are currently living in the United States. And as stressed, common side effects of treatment do include, sexual dysfunction, including erectile dysfunction, and then issues with urinary control, including urinary incontinence. So as the urologist, we commonly see this patient, right? Very stressed, with a new prostate cancer diagnosis. And not only are we talking about treatments, which, potentially include surgery, radiation, things to affect their testosterone production, hormone ablative, treatments, but we're also telling them a lot of these will have effects on their sexual function, right? And so it's a lot to take in for these patients, very stressful, and so kind of breaking all of this down as a means for patients to understand is our goal. I work with another 2 urologists now that do more of the prostate cancer surgeries, and my input primarily is in the recovery of their sexual function. So I meet with patients in this capacity to discuss this, but these are stressful conversations for patients, and we do appreciate that and approach our encounter in such a way at that time. So what is erectile dysfunction? So simply put, it's the inability to achieve or maintain an erection that's firm enough for sexual activity and intercourse, right? And so that can vary from patient to patient in terms of what may be adequate for their specific, sexual habits, what their goals are. But in essence, any patient that comes to us with concerns about erectile function for performance would be classified as erectile dysfunction. And then, a lot of times men come to us, these are uncomfortable discussions for them oftentimes, but we really try to stress that these are common issues, number one. So most men after the age of 50, at least 50% of men after the age of 50 will report some degree of erectile dysfunction. So I try to stress that patients are not alone in this process, especially if we're talking about post-prostate cancer treatment, that these are very common issues, and we have very good treatment options to address most patients who are suffering from these issues. And if you look at the lower stat there, we estimate at least 30+ million American men do suffer from some form of erectile dysfunction, whether that be, from poor blood flow, or that be psychogenic in pathology, that these, issues do exist. Not to go too much into the detail of this here, but in essence, what a good erection is, right? It's blood flow that comes into the penis with dilation or opening up of blood vessels that reside in the penis so that the penile tissue can engorge with that blood. That's primarily controlled from nerves that stimulate those arteries to do that job. And as those arteries allow more blood flow in and there's more expansion of the penile tissue, it eventually leads to further compression of veins and other tunicle layers there that actually lead to more significant rigidity and trapping of the blood to maintain a good erection. So, kind of simply broken down, it's blood flow in and trapping of that blood flow that leads to what an erection is. And anywhere in that pathway, it could be in trapping of the blood, it could be in, nerve input. If we're talking about prostate cancer treatment specifically, nerve input is typically what is affected by these treatments that then lead to poor stimulation of these arteries that then have more trouble responding and then lead to the issues we see with the erection. So simply put, blood flow in and trapping of that blood is what leads to, a good erection. And so just kind of briefly about the nerve input, right? So it's multiple nerve pathways in the body. Some of them are controlled, some of them are not controlled. We have sensory input that comes from certain nerve groups, and then the input in order to open up those blood vessels comes from what's called the autonomic nervous system, which is not something we have direct control over. Stimulation can lead to activation of some of those pathways, but those are involuntary nerve groups. And so what the diagram here shows that there's these nerve plexus in that picture there The prostate is the organ that is in purple there, and all that yellow tissue behind it is nerve tissue. And that nerve tissue, you can see, really is very closely adhered to the prostate. So if radiation is directed to the prostate, or you have surgery that removes the prostate, those nerves are right there and have a very high chance of having some degree of injury or manipulation that may take time for recovery, or in some patients really does not recover if there's such, significant disease, or there's concern that there's disease that is even extending extracapsular outside of the prostate, that they may have to be included in either the surgery or even in the radiation target. So this is kind of just why we do commonly see these nerve, pathologies that lead to erectile dysfunction after prostate cancer treatment. It just has to do with the anatomy of where these nerves are running. So this is just a diagram for patients who we discuss prostate cancer surgery with. This is called prostatectomy, where we remove the prostate. You can see the bladder that has the prostate in between it to the urethra, which is the tube that we urinate through. So the prostate is basically removed from an incision by the bladder and an incision by the urethra. And again, all of these nerves here, where they say neurovascular bundle, is sitting just behind where the prostate is. So you can see, while the prostate is being resected, these nerves are in very close proximity. And so in the end, the bladder is then re-brought back to the urethra, but there's that defect where the prostate was before. So after prostate cancer treatment, we know that a lot of men are going to suffer some degree of erectile dysfunction, right? And so, these stats are quite a broad range, just has to do with different various study types that are out there. But I will tell patients on average, there's about a 50% chance that you are going to suffer some notable change with erectile function that can potentially be in the long run. Now, men that have prostate cancer surgery, I say that that's likely to be actually much higher, even if there's nerve sparing that you'll notice immediately after surgery, where there's going to be need for recovery of those nerves, which can take time to settle down, even up to 1 to 2 years after prostate cancer surgery is performed. So it's not an immediate recovery if there even is nerve sparing that is performed. Robotic technology has really allowed us to, get better visualization deep into the pelvis when we do prostate surgery. But again, as you saw from those previous diagrams, the prostate sits extremely close to those nerves. And despite, the advances with robotic technology and all that, there's involvement of those nerves in a large group of patients. So the expectation too, I tell patients, is that it's not going to be so immediate recovery, but we don't like to do anything typically before a year unless there's severe erectile dysfunction. When I say anything, I mean surgical wise with a prosthetic, which we'll review. But I don't like to do that typically if they're still within the year out, because there's still a fair chance of notable improvement as men get up to that year mark after surgery. So this is just reviewing some broad causes of erectile dysfunction. So most men with ED have some underlying health issue, right? And so that's primarily part of the vascular system. And as we discussed, what leads to a good erection, right? It's blood flow. So some pathology with the vascular system, and that can be influenced by, hypertension. It can be influenced by diabetes, which leads to, dysregulation of those blood vessels. Cholesterol issues, CAD is even a risk factor alone. Cardiovascular disease alone is a risk factor for erectile dysfunction. That makes up most of the patients with ED. But in that other 30% of patients, that's where the prostate cancer treatments do exist, and as they cause ED. And so that's, pelvic surgery, prostatectomy being one of those, radiation to the pelvis, as we do for prostate cancer, as well as men with low testosterone. Some of the treatments for men with more aggressive prostate cancers do include altering their testosterone production, and that can also impact the ability to obtain a good quality erection. So that all fits into that 30% of patients otherwise that have that as a cause for ED. And sometimes, obviously, this is, it's not either you have the underlying health issues or you don't. But, if you have underlying health issues on top of having these prostate, interventions for prostate cancer, you are more likely to suffer erectile dysfunction that may be even more refractory to treatment options that are out there. So, as I tried to allude to before too, is that most men who have erectile dysfunction, the good news is that it can be managed, right? And that's in the very, very vast majority of cases. We have options to help manage their FDED. So this is just some of the options that we're going to go through. These have all been well studied. I don't list them in any particular order of where they're on the screen here, but there are various modalities out there that work to try to improve rigidity, whether that be mechanically to improve the rigidity or pharmacologically to improve the rigidity, so that men are able to obtain an erection adequate for sexual activity. So we'll go through all of these. This is a cellular picture I just wanted to include here, just really for the discussion that, at the cellular level, this is looking at the arteries that we discussed that have to open up and get that blood flow. And there's multiple pathways of regulation here, right? And the treatment options that I just had on the previous slide are working through different mechanisms at a cellular level to lead to relaxation of these arteries, so that better blood flow comes in, right? And so manipulating these various receptors or enzymes, we're able to try to improve that dilation, improve the blood flow, so that patients are more easily able to obtain a better quality erection. So we're able to manipulate this pathway from various different drugs. And so that's kind of the purpose of that slide there. So one of the options most patients at least have some knowledge of are oral options, pills. So they fall into a class called PD-5 inhibitors, which are phosphodiesterase inhibitors. And on the previous slide, that's this group here, where in essence, from blocking conversion to a breakdown product, you actually can lead to increased dilation within those smooth, within those blood vessels, to lead to more blood flow coming in. So that's in essence how these class of medication work. They all work through that same mechanism. So Viagra, Cialis, Levitra, all of these medications are phosphodiesterase 5 inhibitors. They are less likely to work for patients that have more of a neurologic potential pathology. So that does include patients with prostate cancer treatments, because these medications do require stimulation of those nerve groups to stimulate the arteries enough so that there is leading to more rigidity through opening up of the blood vessel. So that is something to be aware of, that I counsel patients on. If they do have these pre-existing issues, they are less likely to benefit from pills, but these pills do work for the very vast majority of patients. Side effects are similar across the board for most of these. They have to just do with dilation of blood vessels in other parts of the body. So headaches, dizziness, some facial flushing, which is redness in the face, nasal congestion, runny nose, visual disturbances from activation of these receptors. Priapism, which is an erection that lasts for more than 4 hours, is actually pretty rare with pills alone. So not so commonly seen. And then myalgias, or kind of body aches or muscle discomfort, we more commonly see with tadalafil or Cialis. So I'm just going to talk about these two medications a little bit more. These are the two more common ones that I use in my practice. Viagra, or also the generic name for that is sildenafil, is a very common medication. Pfizer produced, been around many, many, many years. And it does work well for many patients. So just things to be aware of with it. It doesn't work right away, meaning you can't just take the pill and then 5 minutes later expect it's going to work. So I tell patients on average they should target it at least an hour before planning to be sexually active. Important thing, many patients are not made aware of this, is it should be taken on an empty stomach. So at least I tell patients around an hour and a half to 2 hours beforehand to not have had food before taking Viagra. So that can be difficult for some patients, especially if they're typically more sexually active in the evening after having dinner. That can get in the way of how Viagra is absorbed through the gut. And then ideally, I tell patients you're talking about 4 to 6 hours of ideal benefit after taking Viagra, that most patients will notice the benefit of the medication. Cialis, or the generic name for that is tadalafil. I do use a lot of this in my practice because it's not affected by food, and so I don't have to counsel patients on that. And the other nice thing is that there is a daily dose option of tadalafil, which does not exist for Viagra, and that just really has to do with what we call the half-life, or how long the medication can stay in the system for. So I tell patients, ideally at least an hour, before sexual activity of taking the medication. The longer, potentially even the better. If you're taking it as an on-demand dose, meaning you're taking one tablet, it's a higher dose to get a benefit before being sexually active. You could even take it earlier in the day, afternoon, where it'll have the benefit for that evening. In some patients, it can last in excess actually of 36 hours of having benefit, not meaning that an erection is going to last that long, but that the availability of that medication to result in an erection does last in that time frame. As I mentioned, there is a daily dose option for tadalafil, which also is nice, and there's dual approval for tadalafil for men that also have prostate-related issues and urinary symptoms related to the prostate, so that can be on a daily dose option in that setting as well. So it's a nice benefit. So I do use a lot of Cialis in my practice for the things that we had just mentioned. A step up from pills is what's called intracavernosal injection. So this is something that I teach patients how to do. It's an administration of a medication that's a compound that is administered directly into the penis before sexual activity. It is not really, it's limited availability, so can't go to a CVS or a Walgreens and obtain a medication like this. This is a compounded medication. There's various formulations of this medication, and all of these compounds here are working through basically different mechanisms, as I showed in that cellular diagram a few slides back, to try to work on opening up blood vessels, right? So this is overcoming nerve input, right? This is important to be aware of, because patients that have prostate surgery and had their nerves that had to be impacted because of surgery or from the radiation, these injections can bypass that nerve stimulation, right? So it gets direct into the penis, direct into those blood vessels and the corporal tissue, which fills up with blood, which leads to the erection. So for all my patients that we're going down this pathway, I do a teaching session where we actually will inject a standard dosing of what's called trimix there, which are 3 compounds, to see the response that they get, so we know what's a good starting dose, to administer. Tell patients typically to inject between 5 to 20 minutes before they're planning to be sexually active. That's typically how long it will take for the medication to work. Negatives that this is not really covered through insurance. I've never seen an insurance actually cover any of these medications, so it can be a little bit costly for some patients. It does require refrigeration for most of these compounded medications. And then, some of the side effects, things that we don't so much see with the pills, are a little bit more common with the injection. So as I mentioned before, priapism for pills is not so commonly seen, but it is far more common in men who are doing these injections, which is why I do a teaching session beforehand with them. Pain related to one component, specifically the alprostadil medication component. And then some patients can even get some scar tissue that can form, which can lead to what's called Peyronie's disease, which is a curve that can develop, from administration. So, but definitely much stronger and has a better response compared to the pills alone. Intraurethral gels or suppositories. This is basically administering a medication through the urethra, so the tube that urinate through, to lead to absorption of medication that gets into the corporal tissue and then opening up those blood vessels to get an erection. Limited availability, even with a lot of the compounding pharmacies, because the only compound that's available has to include alprostadil in it, because that's the strongest of all those compounds. And unfortunately with alprostadil too, there can be some urethral burning that's associated with it. So I tell patients, if interested in this option, there's probably around a 40% response rate. But what we do know is that a lot of men who go with this option are more likely to trial an alternative option because of the burning sensation that can be elicited from it. Another thing just to be aware of, so obviously this is something that has to get absorbed through the urethra. So men that have still severe or persistent stress incontinence, this can be difficult for them, because even though they may have avoided if they're well hydrated, that urine that gets into their bladder can immediately leak out of the urethra, and that's going to lead to poor absorption of this medication. So men that have persistent stress urine incontinence, this is really not a great option, for them. Vacuum erection devices have been around for a long time. So this is a mechanical option that basically leads to pulling of blood into the penis that leads to rigidity by opening up blood vessels and getting more blood flow into the penis. And then after the desired rigidity is obtained, an elastic ring is placed at the base of the penis. Similarly, as with the intraurethral suppositories, there's a high transfer rate to other treatment options because alone, what we know with vacuum erection devices in the majority of men, it's just not enough to get the job done, or it leads to too much discomfort from the pressure that's created from the vacuum device, and even from having the ring clamp on at the base of the penis that can lead to discomfort or even interference for some men with sexual activity. So not such a great overall tolerance rate with it, but it is an option, it has been around a long time. And even is being utilized in penile rehabilitation programs to just try to, as the effort to maintain elasticity of the penis so there's less loss of length after prostate cancer treatments. So the last thing just to talk about are surgical options, and these are implants, and these have been around for an excess of 50 years. These are very, very good, implants. They're an excellent surgery that leads to very high satisfaction rates. There are two general types of prosthetics out there. One that's an inflatable device with 3 components, a pump that sits in the scrotum, and then cylinders that go into the penis that lead to rigidity from activation of that pump, and then a malleable device where there's manipulation of a device in the penis that's always kept rigid, but you can manipulate it with your hand for the desired direction of where you want it to point. So I tell patients between both of those devices, there's greater than 90% satisfaction rate. So a really, really good option for men that have refractory erectile dysfunction and are willing to want to pursue a surgical intervention. So here's just a little bit more information about the inflatable device. So it works through a pump that is squeezed in the scrotum. It takes fluid from a reservoir which sits in the abdominal cavity in essence, and shunts that fluid from the reservoir into the cylinders into the penis. That leads to rigidity. And then when patients are done, there's a deactivation button on that pump that's squeezed to take the fluid from the cylinders in the penis and shunt it back into the reservoir. So a very operable, implant, very high satisfaction. We do see slightly higher satisfaction rates with this compared to the malleable, just because it's a little bit more realistic, and it has the placid and rigid state. So any procedure has drawbacks. Number one, I tell patients, an implant is not a natural erection, right? In essence, you're relying on a device now that's going to maintain the rigidity for you to be able to perform. So it's not a natural erection. There are drawbacks to implants. It doesn't get all the way to the very tip of the penis because of just the anatomy. So there's not so much glands engorgement, or there's really no glands engorgement that occurs from these prosthetic devices. So that's a difference to natural erections. And that there is always a risk of, the malfunction of the device over time and the risk of infection, right? These are foreign bodies being placed. And if this device were to get infected, it potentially would have to be removed, to manage the infection. And then here's just the diagram of the malleable device. So no, pump, no reservoir. It's just the device that maintains the rigidity, and by manipulation with the hand, the penis is brought into the desired position. I do kind of counsel patients in this direction for specific, other medical issues, right? So patients with spinal cord injuries or Parkinson's, for example, we'll see patients that have poor hand dexterity. Operating the pump device can be a challenge for them, right? So putting a device like that in when they don't have good hand dexterity really is not going to offer them a benefit unless they have a partner who is willing to actually cycle the device for them for it to be used. So this would be more of a reason to push in this direction. It does have a lower risk of complications because it's a more simple device and a lower risk of infection. So positive related to that device. Last slide here, just to briefly kind of discuss penile rehabilitation. So basically, this means how can we optimize sexual function for men after having prostate cancer treatments? And as we went through in this talk, there's many reasons for men to have ED. Prostate cancer treatments can exacerbate the issues of erectile dysfunction, and so recovery from them can be a little more challenging than patients that don't just have a prostate surgery or radiation to their prostate that was indicated for prostate cancer. So one thing, as in anything really in medicine, right? And there's not one program or one size that fits for everybody, right? So was there nerve sparing? All this kind of gets factored into our discussions. Was there pre-existing erectile dysfunction? Are there pre-existing comorbidities that we need to be aware of? Are men experiencing stress incontinence after these treatments, right? Because like I said, that's not a good option to use an intraurethral gel, even a vacuum device, for helping to get some elasticity to the penis, because they're going to be leaking with these devices or with the administration of the gel. So all this really gets factored in terms of what's best for each specific patient. But in essence, I typically would like to see patients pre-op before having prostate surgery, so we can at least start these discussions. I do think it's a good option even just to be on a daily tadalafil, to help even beforehand getting better blood flow in, helping to maintain elasticity of the corporal tissue in the penis. And then I like to see patients, 6 weeks after surgery to start a little bit more of where these discussions are. Obviously, every patient's different. Some patients need longer for recovery, and these are really not priorities. And that's absolutely fine as well. But I do like the idea of daily tadalafil, like I mentioned, just to help with increasing blood flow. It does require the need for nerve activity. So I advise patients, even with the pump, right? Our goal is really not to just get the best quality erection 2 to 3 weeks after these surgeries or radiation, right? Because it can take much longer for there to be recovery, and it's kind of managing those expectations. But I do utilize all these options that we discuss as a means to try to get patients in the best time frame for them to where they're comfortable and happy with the quality of their erections. And that's it for my portion of the talk.
Great. Thank you so much, Dr. Caputo. All right. And next up, we have Diana Tebow, PT, DPT and pelvic floor physical therapist.
Thank you so much. Thank you, Dr. Caputo, and thank you, Ashley, and thank you all for being here today. So yes, my name is Diana Tebow. I'm one of the pelvic floor therapists here at Atlantic Health. And today I'm going to chat a little bit about fitness with a prostate cancer diagnosis and urinary incontinence, which is a common symptom that I see, especially post-prostatectomy. Okay, so let's get started. My slides don't want to move. Let's see here. Okay, there we go. All right. So let's start off with fitness and exercise. Okay. So current recommendations by American Cancer Society is at least 150 minutes per week of moderate intensity exercise. This 150 minutes can be broken down into smaller intervals, as little as 10-minute intervals. Okay. Or a minimum of 75 minutes per week of vigorous intensity exercise. In addition to this, they also recommend 2 to 3 times per week of resistance and flexibility exercises. So in the following slides, we're going to go through a little bit of what that might look like and how you can determine what your exercise intensity is. Okay, so for those of you who are already involved in an exercise program, that's wonderful. And if you feel comfortable kind of changing things up to meet these goals, great. But for those of you who may not have an exercise program that you're in right now and are interested in starting one, but don't know really where to begin, please feel free to talk to your oncologist about your interest in exercise and whether PT or a supervised exercise program could be a good idea for you. Okay. So let's get into a little bit of exercise intensity and how you can gauge where you're at. So this study also looked at percentage of heart rate max and rate of perceived exertion. So two different ways to kind of help you to gauge where you're at and how intense your exercise is, okay? So we're gonna get into a little bit of each of those. So for example, how to calculate the percentage of heart rate max that you're in. Okay, so here's an example. So you're 56 years old and you decide you want to perform moderate intensity exercise. So to figure out your heart rate max, okay, this study suggests subtracting 56, so your age in years, from the number 220. All right, so that would give us 164. That would be your maximum heart rate. Then, in order to find out the percentage of that heart rate that you need to be working at in order to achieve that moderate intensity exercise, we would take your heart rate max and multiply by 0.60 and then by 0.84. Because in the chart before, right, we need to stay between the ranges of 60 to 84% to be in moderate intensity exercise. Okay. So what that would give us with the calculations is that for a person who wants to exercise at moderate intensity at the age of 56, you're looking to stay in between 98 to 137 beats per minute. Okay. So that's a great objective way to really measure your exercise intensity. Whereas rate of perceived exertion is more subjective, okay? So it's on a scale of 6 to 20, and pretty much based on what you're feeling, what your symptoms are as you're exercising, that's what you would rate yourself as. And that number would correlate to which exercise intensity you're in. So for example, okay, so we know from the previous chart that moderate intensity exercise would be between an RPE value of 11 and 14. So say you're jogging, okay, and you start to feel a little out of breath, but you can still hold a conversation with your friend next to you. So maybe you rate yourself somewhere like number 13, okay? That would correlate to moderate intensity exercise. So this is, relatively easier way to calculate. But if you ever have any questions, again, a physical therapist, an exercise instructor can help you to determine which intensity level you're involved in, okay? So let's talk a little bit about the different types of exercise. So for aerobic exercise, so that 150 minutes of moderate intensity or that 75 minutes of vigorous intensity, we're talking about things like walking, running, swimming, cycling, dancing, playing tennis, okay? Ways to get your heart rate elevated. When we talk about resistance training, we're talking about using bands, weight machines, free weights, body weight exercise, okay? And for flexibility, we're thinking full body stretching. Yoga is a great way. But if you've noticed, right, there are not specific parameters set for the resistance and flexibility training because that depends so much more on where you're starting from, okay? So of course, the goal is to increase your strength, increase your flexibility, but a major part of how much you should be lifting, how frequent, really depends on where you're beginning from, okay? So again, a PT can really help with that in guiding you to reach those goals. Okay, so we're going to talk about the benefits of exercise. So of course, we know that exercise can benefit us so much in our daily lives. But then when we are faced with a prostate cancer diagnosis, those impacts become so much more vital. Okay, so improving cardiorespiratory fitness, increasing muscle strength and function, improving your body composition, improving your balance. So some of the treatments for prostate cancer can affect your balance. So exercise can absolutely help to improve that. Decreasing your fatigue, helping to improve your mood and decreasing anxiety, which is huge. Okay. All right, so now, like I said, a common symptom, a common thing that I see in the clinic in men post-prostatectomy is urinary incontinence. Okay, so this is going to be geared towards that. I felt like it was really important to talk about this, being that I see it so very often. Okay. All right, so how exactly do we define urinary incontinence? So urinary incontinence is the involuntary passage of urine, and it's common in about 80% of men post-prostatectomy. Okay, and the big question that I get is, well, why did this happen, right? Like I didn't have this before, and now post-prostatectomy, why am I having this leakage? And it's really hard to answer that question because there's so many factors that can contribute to incontinence, okay? So I listed some of the factors here. So your age, your specific anatomy, your weight, your level of physical activity, and also changes to your structure and or trauma to surrounding anatomy during the surgery, okay? So what I'd like to do is talk a little bit about what changes in your anatomy post-prostatectomy and what we can do from a physical therapy standpoint to help, okay? So let's review the anatomy a little bit, all right? So as you can see in this picture, we have the bladder, and then right below the bladder sits the prostate. From the bladder through the penis, we have the urethra, which is the tube that carries the urine. Okay, and then as you can see on the bottom, we have a group of muscles known as the pelvic floor muscles. Okay, so the pelvic floor muscles are huge to us as pelvic floor physical therapists. And being that we work on the muscular system, I'm going to describe a little bit about the role of pelvic floor muscles. So this way you can understand what we can do to work on them to help you. Okay. So the pelvic floor muscles, okay, so they have huge roles in sexual function, urinary function, bowel function, and core support. Okay, so there's a couple of layers of these muscles. When I say core support, I think that most people's minds goes directly to the abdominal core muscles. And that is correct, okay? The abdominal core muscles are part of the core, but the pelvic floor muscles act as deep core support, okay? So when we're standing, when we're walking, when we're moving around, those pelvic floor muscles are also responsible for helping us to keep us upright, okay? All right, so let's talk a little bit about what changes, actually, let's talk, a little bit about what changes post-prostatectomy. Okay, so let me just bounce back here for a second. Okay, so when we're talking about normal continence, okay, we have a few things that contribute to keeping us continent, okay? So for example, all right, prior to the prostatectomy, you're able to make it to the bathroom, right? You're able to make it to the bathroom without having to worry about leaking. Okay, that's in part due to multiple factors. Okay, so for example, our nervous system, we need an intact nervous system to be able to control the internal sphincter. Okay, the internal sphincter in this picture is depicted by that arrow A. Okay, what happens, simply put, is the bladder starts to fill. As the bladder is filling, okay, it sends a signal to the brain saying, okay, the bladder is getting fuller. We're going to need to void soon. The brain then sends signals down to that internal urethral sphincter to contract and prevent that bladder from leaking, okay? We also have what's known as the external urethral sphincter. Again, on the picture on the left, it's depicted as the arrow B. The external urethral sphincter, for example, you can activate that, say you're urinating and for some reason you want to stop the flow of urination. That's the job of the external urethral sphincter. So we can actually control the external urethral sphincter. So the internal urethral sphincter was something that happened automatically, okay, by our nervous system. We don't think about it, we don't control it. But when the prostate is removed, so is that internal urethral sphincter. Okay, so what we're left with to work with is the external urethral sphincter and the pelvic floor muscles. So both the external urethral sphincter and the pelvic floor muscles can actually help to prevent the leakage of urine. Okay, and sometimes it takes a little bit of time for those muscles and those tissues to become healthy again after a surgery. But sometimes pelvic floor therapy is needed to help with the coordination of those muscles, okay? So I want to talk a little bit about what we do in terms of pelvic floor therapy. I think it's been really kind of out there, especially in social media, about how important Kegels are, okay? And Kegel is what's known as a contraction of the pelvic floor muscles. what happens is that sometimes people start performing these Kegels, but actually it takes a lot more than just muscle strengthening to really train the system to utilize these muscles properly. Okay, so I'm going to get into that a little bit. All right, so this is where pelvic floor PT comes into play. All right, so there's evidence that suggests coming to PT before a prostatectomy can really help to reduce time to continence in the short term. And that's because we look at the health of the tissues. We look exactly how you're performing these contractions. Okay. Coming to PT after a prostatectomy has also been shown that compared to patients who just do their exercises on their own, that actually the patients who come to PT have a faster recovery and increased likelihood of regaining continence. Okay. All right. So what exactly does pelvic floor PT involve? All right, so it involves a thorough evaluation and assessment. Pretty much we're looking at your pain levels, okay? If you're feeling any pressure, your urinary habits before the prostatectomy and post-prostatectomy, your bowel movements, again, pre and post, how they have changed, if at all, sexual function, your muscle function. So we're gonna take a look at those pelvic floor muscles to see exactly how they are working and what the health of them is like after the prostatectomy. Your mobility. So we're looking at your joints. We're taking a look at how you move. Okay. Once we determine and get that assessment and evaluation underway, then we're going to form a really comprehensive and individualized treatment program to reach your goals. Okay. What I like to say is that with PT, a lot of times rehab in general, it's never a linear progression. There's always going to be some blips along the way. That's just life, unfortunately. But when you're coming to physical therapy, what's so great about it is that we can really help to troubleshoot those issues and help you to progress to reach your goals. Okay. We use a lot of different skill techniques. So we use a lot of manual techniques, exercise training. We also use biofeedback. So there are many ways to perform biofeedback. Okay, biofeedback really means you understanding what your body is doing. Okay, so some of the clinics actually have a real-time ultrasound where you can actually visualize your muscles and see how well those muscles are functioning, how well they're contracting, how well they're relaxing. So that can be really useful in rehab as well. So I just want to get into a little bit about the stages of rehabilitation, okay? So first, we're going to help you identify your pelvic floor muscles and be able to understand exactly how to recruit them and which ones you need to recruit. We're going to talk about balancing the strength and length of your muscles. So like I was saying before, it's not all about performing Kegels and strengthening those muscles, because if those muscles are too tight and they're too spasmed, we can strengthen for a very long time, but we're not going to achieve the same results that we would if those muscles were at their proper length before we start strengthening them. Okay, so really the health of those muscles is vital. Okay. We're going to be talking about coordinating your breathing and all of your core musculature. Okay, so your breath plays a huge role in how well you can actually coordinate those pelvic floor muscles and core muscles for optimal support. We're going to also talk about managing intra-abdominal pressure. So for example, think about when you sneeze or when you cough. There's a lot of pressure that builds up in your stomach that can easily put pressure down onto the bladder, okay? So we're going to teach you how to coordinate those pelvic floor and deep abdominal muscles to counteract that downward pressure to prevent leaking. Last but not least, we're going to apply all of this to your functional activities or recreational activities that you would like to get back to, okay? Because that is optimally our goal, is to get you back to where you'd like to be, okay? All right, and then I just want to end with a little bit about education and what we do. Okay, so part of our job is to really help to guide you in this process, to really help give you the education you need and the tools you need to manage these symptoms, okay? For example, we'll talk a lot about independently managing certain things such as constipation, okay, bladder irritants, how to safely empty your bowel and bladder so to prevent any damage to the muscles or any increased tension to those muscles, okay? We're also going to talk about planning for the future. So your goals become what we focus on, and we want to get you back to where you envision your life to be. Okay, so with that being said, if you're interested in pelvic floor therapy, there's a couple of numbers that you can call. You can to schedule. You can also take a look on the website, and if you're able to, you can always copy and paste that into your browser. If not, you can go to the Atlantic Health website and type in pelvic floor therapy services to see where we provide pelvic floor PT throughout Atlantic Health. Okay. And just a little bit of a tip. So if you're interested in therapy, especially before and after prostatectomy, and you have your date of the prostatectomy set up, you might want to call in sooner than later, as we typically get pretty booked. So you might want to just schedule that ahead of time. To do that, you're going to need a script from your MD. Okay. So thank you very much again for letting me share, and I'd be more than happy to answer any questions.
So I would like to say that we appreciate you joining us today. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to the survey has been added to the chat for your convenience. And a special thank you to Dr. Caputo and to Diana Tebow for dedicating both of your time and your expertise today. If you have any additional questions or comments, you can send an email to communityhealth@atlantichealth.org or call 1-844-472-8499 option 3. And that concludes today's webinar, and I hope you all have a great day.
Thank you.
Good one, everyone.